Good afternoon. We have today a very distinguished panel with me. On my left is Professor Horst Sievert from Frankfurt, Germany. To his left is Dr. Saibal from Cedar Sinai in Los Angeles. And to his left is Professor Meier from Bern, Switzerland. Welcome to the interview. So this afternoon we are going to discuss two very important topics. The first topic is patent foramen ovale, and the second topic is, of course, the left atrial appendage. Both topics in the last few months have been very popular in the news. So I would like first to start with PFO, and I'm going to turn to the first slide here. And the major reason we are discussing patent foramen ovale is the association, of course, between PFO and the stroke prevention. There is a big debate, especially since now the three major trials have been concluded. The first trial was the closure one. The second trial is, of course, the RESPECT trial, and the third trial is the PC trial, which Professor Meier is the principal investigator on that. All these trials, as you can see in the slide, the closure one, the RESPECT, the PC trial, the reduced trial is the Gore Helix septal occluder is still ongoing. A trial, we will discuss that shortly afterwards. The closure one enrolled 960 patients. The randomization was 1:1. And the entry criteria for the trial was any patient who had clinical stroke or TIA. They did not, unfortunately, use radiologic evidence of confirmation of a TIA. So that was one of the drawbacks for this trial. The screening event from the time of the stroke to the inclusion in the trial was about 6 months, and the device arm, they received the Starflex device with 6 months of clopidogrel and the 24 months of aspirin. The control arm, which is the medical therapy, 24 months of aspirin and or warfarin or both, depending on the physician preference. Again, the device was the Starflex from NMT. The endpoint was a stroke or TIA. The RESPECT trial is the largest trial, 980 patients. Randomization was 1:1, and the entry criteria was stroke as confirmed by MRI. The screening event was a little bit longer, 9 months, and the medical arm received warfarin or aspirin plus dipyridinol, and the device was the Antiplatelet device, and again the endpoint was stroke or death. The PC trial, as I mentioned, was primarily in Switzerland, but it was multinational, 414 patients, 1:1 randomization. Again, the entry, clinical and radiologic evidence of stroke or TIA. Screening event was up to 5 years. The medical arm was warfarin or aspirin plus minus dipyridinol, and the device was the Antiplatelet, and again the endpoint was stroke or TIA or death. So with this, what I would like now is to open up the discussion and talk about these trials. I'm going to start with Professor Sievert to tell us about these trials and your opinion about this.
I think the most important message from all these three trials is that PFO closure is safe. In closure one, in PC, and in the RESPECT trial, there had been no more adverse events in the invasive group of PFO closure compared to the medical arm group. And that means at the end of the day, medical therapy, which has to be given lifelong, is actually more invasive than the invasive strategy. Because PFO can be closed in 15 minutes, whereas when you take Coumadin or aspirin, it's a lifelong thing with additional risk with every additional year of life.
But sure that the trial, demonstrated that PFO closure is safe. The question at hand that the three randomized trials did not meet the primary endpoints. So how do you justify closing a PFO in these patients?
That's the way how these trials have been designed, because all of them are superiority trials. But when you look at the low risk of the procedure, which actually has been proven only by these trials at the end, then it would have been okay to have just non-inferiority. So we have now a safe procedure, which is not more risky than medical therapy. It's a one-time procedure with the same effect, non-inferiority.
Okay. Dr. Meier, what do you think of the trial, especially you were the PI on the PC trial? What's your summary of these trials?
I would stress the exact same thing that Horst just mentioned, meaning that it's not superior. You still can give the patient a choice between a once-in-a-lifetime procedure that takes half a day, going in and out, has no usually no risk and no sequela. You can lead a normal life like the same evening of the intervention against taking lifelong anticoagulation with an increasing risk of bleeding as you grow older. And I think if you put it to the patient like this and hint that probably you even make the better choice when you choose the device, because in all three trials the trend was going in favor of the device. It was just not, follow-up was not long enough, there were not enough events happening to show the difference. Then I think the patient will wisely decide for the once-in-a-lifetime procedure rather than lifelong anticoagulation with all the risk. It may be different in somebody who needs anticoagulation anyhow for another reason, but the others, I think, will wisely decide for the PFO closure. This is what happens already in many countries where the device is freely available.
So in your opinion, one of the reasons that the trials were not positive is the duration of follow-up for these patients?
Yeah, the trials were designed at the end of the last millennium, so to speak, so more than 10 years ago. When we actually thought that not closing the PFO to be more risky than it turned out to be. So the control group had fewer events than we thought, which is good for the patients, but of course the trials were misdesigned in that respect. So they will still reach their endpoint, but we cannot add patients now that that randomization has been closed, except perhaps for the reduced trial. But of course, we can prolong follow-up, and you just have to sit on the patients that have been included and wait for more follow-up. And there will always be more events in the control group, and the older they get, the more also bleeding will become an issue in those being anticoagulated.
So it's not only the follow-up; it's also the trial design. Because when you designed this trial in '99, you thought, okay, it should be superior. So this was a 1-second decision. We should go for superiority. But if you at that time would have decided, let's go for non-inferiority, then these trials with the same results, same follow-up, would be named positive trials.
So you think a non-inferiority design will be acceptable, for example, to the FDA, that, okay, if we design this trial, because neurologists look at this, you know what, I can give this patient antiplatelet therapy lifelong and avoid the risk of a procedure, especially the first trial, the closure, had a lot of, device-related events, complications, inexperienced operators. So I must admit that looking at the overall picture of the Closure 1 trial, if I was a neurologist, I would view this with really skepticism that, you know what, this is not a safe device. A lot of patients developed AFib. 5.7% of patients developed dysrhythmias. So how, Saibal, how can you convince your neurologist that this is a good thing to do for your patient?
So first of all, I totally agree. I was part of the Closure 1 trial, and I agree with you, Ziyad, that there are differences in devices, and there was an issue a little bit in the Closure 1 with some safety events, more than the Antiplatelet PFO. On the other hand, in the Antiplatelet PFO trial, as well as the PC trial, I think the safety was better. The second issue that you nicely brought about the duration of time, but I think more important is the case selection. I think, as I've told before, one of the biggest problems that have happened in these trials is these devices were available to us. Yeah. So we often used clinical judgment and didn't randomize the most high-risk patients and treated them off-label.
That's right.
As a result of that, we were led with a lot of patients, with low-risk patients, potentially low-risk patients, where to show a benefit with a new therapy is more difficult. And third, of course, as you mentioned, is the duration of follow-up in the Closure 1 was only 2 years. The RESPECT trial, unfortunately, is going to be longer, and we feel that if these are followed for a longer period of time, potentially those curves will separate and we'll actually be able to show a benefit. Now, to convince a neurologist whether this is the right thing or not, at the present moment, it is a little difficult. But at the same time, we have to say that all the 3 trials, even though they never met their actual endpoints, they always showed a trend towards superiority.
That's right. That's right.
None of them, in none of the studies, did they actually show that they were worse than medical therapy.
Yes.
And the other thing is that we have to realize...
Well, the only one, the Closure 1, in terms of complications,
yeah, but if you look at it
more complications.
That's very interesting. If you add all of that together, even if you add all of that together, it's still, the event rate was 5.5 versus 7.7, 7.7 being in the control arm, 5.5 in the device arm, but it didn't achieve statistical significance, but it still was in the trend of superiority. So I think there is this positive signals in the favor. The other thing we have to remember that it's not closure versus medical therapy, because all these patients who were treated were all treated with antiplatelet agents, even the device ups. It's actually a hypothesis of device closure plus antiplatelet is better than medical therapy alone, because you never took them off completely. If I'm correct, I don't know.
That's not correct for the respect. The PC trial, it was left open, and most were actually off treatment.
I see.
After closure.
Yeah, yeah.
I see. So that part I didn't know.
But also in the control group, not everybody was on treatment during the whole duration, so that was not controlled.
But in any case, the differences between medical treatment and device closure are very, very small. I think that's everybody will agree.
But why is it very, very small? Yet when we were doing the retrospective analysis for all these things, we always thought that the difference was, significant, and because of that, the trials were designed. And yet when we did the randomized trials, now we found that the difference is very, very small. You need much longer duration, perhaps much larger sample size. Why do you think, has there been change in the management of stroke and PFO? And
not really. I think the results with closure came out as we had expected, like 1% or less than 1% breakthrough events in spite of device closure. What was much lower than we had expected was control group.
The medical therapy,
And of course, when we did non-randomized comparisons, you looked at a series of PFO closures, you saw that they had a low event rate, and then you compared it to the background of historical reports on what happens if you don't close, and those were somewhat either overestimated, those risks, or it was a particularly high risk group that was looked at in the so-called drug treatment real life studies on PFO without closure. So the difference is low on a very low level, but in the PC trial, for instance, reduction of stroke was 80% relative reduction. That's a lot. I mean, that means you avoid 4 out of 5 strokes that happen in spite of drug treatment.
Let me now ask Horst. You heard Bernie this morning talk about meta-analysis. He wants to combine the two trials, the PC and the RESPECT trial, right? What's your thoughts on this, and do you think regulatory agencies, be it in the US or in Europe or Korea or wherever, do you think they will accept such analysis? Should they accept such analysis?
Well, they should, but the FDA probably will not accept anything, as they usually don't do. I think it's a good idea to combine this. The question is, should closure 1 be included in that analysis? I think not. I think not, because we have actually proven in randomized trials that Starflex occluder was less good than the Amplatzer. So we have good reasons not to include the closure 1.
Different devices. So.
Different devices. That's what I mean.
At least the PC and RESPECT have similar devices.
Bernie, what's your take on the meta-analysis issue?
Yeah, I think the meta-analysis will turn out positive, particularly if you do it on a patient-based basis. So far, there have been meta-analysis just on the average of the 2 studies, but it will be positive because the RESPECT trial, as you know, just kind of missed a couple of more events, and it would have been positive in itself in the intention to treat arm. So add, this the overhang of events in the PC trial, that's more than they need to make their trial positive. So that's going to be a deal, but of course the FDA does not have to accept that. They can just look at each individual randomized trial and say it's 3 negative trials. Again, the problem is if you go in for a superiority, we should actually submit it to the FDA as an alternative to medical treatment and let the choice to the physician and the patient. They should admit that this is at least as good a treatment for it than anticoagulation. So they should make it available for those who want it.
I mean, there are many other fields in medicine where people don't, even agencies, don't look at mortality and stroke and other things. For example, hip replacement.
That's right.
Actually, hip replacement is more dangerous than conservative therapy. No question about that.
That's right.
And it's
But
only
still, it's the
morbidity.
decision of the patient because it's quality of life.
But I think, you know, we all know the political issues around devices in the US, and it's a very highly regulated market, different than orthopedics or other specialties. Saibal, just give us, you know, very briefly the REDUCE trial. Describe it for our, audience.
Well, one of the unique features of the RESPECT trial, it has some similarities between the RESPECT and the...
You mean the REDUCE trial?
REDUCE trial, right? So it's a randomized study of the device that is the Helix septal occluder, or the new device GSO2, in patients with cryptogenic stroke or patients with a TIA who are positive with an MRI scan.
Positive MRI,
and they get randomized 2-to-1 instead of 1-to-1 to device plus antiplatelet therapy for short term versus just antiplatelet therapy alone. And the antiplatelet therapy is aspirin, clopidogrel, or I think the combination. I think that's all. And the follow-up is actually more interesting. The follow-up is going to be at least to 5 years. The primary endpoint is going to be analyzed at 2 years, but all patients have to be followed for 5 years.
Great.
The downside of that trial, to my understanding, is they're using the Helix device, which is actually outdated, which has a very high residual shunt rate.
It's the Helix device still in the US until the GSO gets approved. It's not.
No, that's not true.
We just converted to the GSO.
Correct.
We just converted.
So for the first 100, I think there are approximately a little bit
More
over
than
100 patients enrolled, and all the sites were getting now the GSO2 device.
That's right.
So every patient
at least half the patients will be, as you mentioned,
will get the
that is going to be one of the drawbacks for the study because you know two devices they're using.
Right.
Okay, last question on PFO. We are now in April 2013. I want the predictions for next year when we come back here in 2014. Do you think the PFO closure will continue with us? Will the FDA approve PFO closure to prevent stroke in these patients? Yes or no?
Yes.
Saibal.
I think yes.
I'm afraid no, but I mean there is the rest of the world. I think in the rest of the world about 1 million PFOs have been closed, and there are a lot of people convinced, and PFO closure will go on even if FDA puts a temporary moratorium on it, which probably is going to be the case. They're going to ask for more data, wait for an additional randomized trial, but PFO will prevail. PFO closure will prevail around the world.
Okay, so what we're going to do now, we're going to move the topics and discuss the left atrial appendage and talk about the efficacy of a closure. So what I'm going to show you here that currently we have two major devices that we are using to close the left atrial appendage, the Watchman device and the unplastered cardiac plug. There's no question that the Watchman device underwent thorough randomized trials. We have the first trial, which was the PROTECT AF trial. Then we had the continued access registry. And then we have a smaller trial. It was not randomized, the ASAP trial. And then finally, another randomized trial, the PREVAIL trial. All four trials, they have demonstrated the safety of the procedure and, of course, the efficacy. And actually, as we all remember, when the PROTECT AF trial concluded and the manufacturer went to the FDA panel voted 7-5 to approve the device, but unfortunately the FDA itself decided that we needed more data, and hence the PREVAIL trial. So PREVAIL trial presented at the ACC in March in San Francisco, and we all know that. So now let's open the trial, and I'm going to start again with Horst. What's your take on the appendage closure? Do you think this is a technique that we should definitely now start adopting it routinely for patients who are receiving Coumadin, or do you think it should be preserved for patients that are, for example, high risk for Coumadin?
You're asking the wrong person, because we are offering this as an alternative since 2005. But these studies actually gave us additional evidence to do so.
Saibal, what's your take, since, of course, Horst is doing this routinely in Germany. Nobody is overseeing him. But unfortunately, in the US, we have the FDA is watching every move we do. So what's your take on that, Saibal?
I philosophically do agree with Horst, by the way. But because we live in the US, both of us, we have constrained by some regulations. But unlike the PFO studies, I think we have here at least managed to convince that LA appendage occlusion is a hypothesis, and it's a proven hypothesis that it actually can prevent strokes, at least equivalent to medical therapy, optimal medical therapy. And the optimal medical therapy in this case being only warfarin. There's no studies with the newer drugs. So based on this, at least I feel that there's evidence, or at least there's reason to at least give it to patients who are having difficulties with Coumadin, or have failed Coumadin therapy, or who are extremely difficult to take it because they're on double antiplatelet agents.
But the trials that we're doing or concluded in the US, it's for patients who can tolerate Coumadin.
Right.
So there's no trial except the ASAP trial, which is not randomized trial, for patients who were, high risk, or they had bleeding or something like that.
Well, realistically, we know that over 95% of people in these studies came off Coumadin successfully. And so if a patient can tolerate a short duration of Coumadin or dabigatran for, like, say, 2 or 3 months, I'm happy to put that person into a study. And I think in the CAP registries, most of these patients had actually relative contraindications to long-term Coumadin. See, the right word is long-term. So I think if the patient tolerates short-term, I think it's a very reasonable thing to. I think most patients can tolerate short-term. Is you give them a closure device, you give them aspirin or Coumadin, and now, according to your data, aspirin or Plavix, and then take them off long-term. So I feel this is a big field, and I have a feel that it is extremely relevant to the population that we are seeing.
Great.
So if there would be no FDA and so on, you would offer this as an alternative as well?
Well, I can't in the US as patients.
If there's no US, no FDA.
Oh, yes, I would offer it to all patients practically.
All patients. Bernie, I know your opinion. I know your opinion about PFO, and you believe that every PFO should be closed. How about the appendage?
Well, as Horst, we can offer it to everybody in atrial fibrillation as an alternative to anticoagulation, and actually the studies in this case have shown it as an alternative, not as a superior treatment that should replace the old drug treatment. But few people elect that because we have to, in contrast to PFO, we have to tell the patient that it is a fairly difficult intervention. So if PFO is at the low end of intricacy with intervention cardiology, LAA closure is rather at the high end. So there is a risk of complications. So the patient more often than not will decide for the pill, even though he knows he's going to have to take it for the rest of his life. And again, the treatment would be hopefully a once-in-a-lifetime treatment. So I think the patient selection here will be completely different from the PFO. Both are preventive things, or you're not freeing the patient of symptoms or pains or shortness of breath as you do with PCI or TAVI. But you just do it to maybe prevent something that may or may not happen in the future.
It shows, again, little mistakes in the study design. Right. We think that there's enough evidence for LA closure because PROTECT-AF is a positive trial. It's positive because it's designed as a non-inferiority trial.
Right.
Yeah.
So same thing.
Yeah, but putting that into perspective, the difference between PFO, I think I agree with Bernhard, there's a difference in the procedure. This is a much more riskier procedure in general than a PFO closure. And that's why I think if I remember correctly, the FDA was not concerned about the efficacy, but was concerned more about the safety issue of the procedure.
Safety of the procedure, definitely.
And actually, we demonstrated in the last 2 studies, the CAP and the PREVAIL, that we have reduced these safety events dramatically compared to the original PROTECT-AF trial.
I'm going to ask a political question, and irrespective of manufacturer. Now, I assume all 3 of you have tried all the devices, the Watchman, the Amplatzer, and the Lariat. Given, availability of all of these things in your lab, if you have a patient that you want to close their appendage, what would you do, and what would you use, and why?
Well, there are some anatomical restrictions, as you know, so length of the appendage, diameter of the appendage, multiple lobes, single lobes, and so on. But the important question behind your question is, can we accept other devices and assume that there's a kind of a class effect or not?
Yep.
And I must admit that's something I really don't know. And looking at the data, I think we probably should not invest millions and millions to have a head-to-head comparison between different devices, but I'm not 100% sure about that.
Yeah. Saibal, what's your take? What would you use?
So we at the moment, as you know, we have two sets of devices: is the endovascular approaches and the epicardial approach. The epicardial approach, as Horst mentioned, is a little bit more selective because you can see that you need to have a patient who's a naive chest, who doesn't have a previous thoracotomy.
Of course.
And the appendage has to be a suitable size, shape, and positioning. So as a result of that, what happens in Cedars, well, this is what we actually do. We take every single patient who comes there and you see if he can be included in a certain study.
Yep.
And the second thing we do is if he can't, we see if he has a thoracotomy before. If he has a thoracotomy before,
of course, Lariat is out.
If he doesn't have a thoracotomy and say he's CHADS 1 or 2, we do start with a CT scan. And if the CT scan is not conducive to a Lariat, I don't even bring up the physician. But if his CT scan is,
yes,
then I tell the patients like this. I tell them, look, the Watchman device is easier for me to put in. I have a higher success rate, and there's data to support it. The Lariat device, I have less experience. We are reasonably safe in doing the procedure. One advantage, potential advantage, is nothing is left inside the heart. And so potentially you can come off all agents potentially, and you have less chance of thrombus. So I just leave it like that, and then I make the patients decide if they want to go the way.
So do we need additional randomized trials for the Lariat and for the ACP?
I think the ACP, I think the ACP does need to have a trial.
Yes.
And I think that it shouldn't be a trial against another Watchman device, but should be a trial against best medical treatment.
Why?
And because I think one of the good things,
especially if they approve the Watchman, then it will be very difficult to enroll patients against medical therapy.
Right. That I agree with you. That's going to be a challenge, and I know that. If the Watchman gets, I think it should be approved, and if the Watchman does get approved, then I think there's reasonable sense to make a trial against device versus device and be non-inferiority. It just shows safety events are equal and efficacy is in the same ballpark.
But no, they already have the next generation of the ACP, which is the Amulet.
Right.
So do we need another randomized trial, Amulet against ACP?
No, I think the Amulet is going to be incorporated into the ACP study. So once the Amulet goes to its pilot phases, it'll be added into the ACP study.
Bernie, what's your take on the appendage?
Yeah, I also think that, the Lariat technique is not a device technique, so it should not be compared with the device techniques. It's a semi-surgical. Yeah, it's a closure. Closure is fine. Whatever you select between the device, of course, I'm taken because over 90% of our cases are Antiplatelet cases, but I would say the difference is very small. So I don't think you should have one device run against the other. Both devices work well. I would not be afraid to take patients off any drug, which we do after putting in the device. So there, the difference to the Lariat technique may no longer be there, except that the patient likes to have no device. So for me, the easier implantation compared to the Lariat would bias me to continue with device implantation.
Great. Let me play the devil's advocate, and the drug proponent people, they say, well, now we have safer drugs, better than warfarin. Do you think we should do another randomized trial against these drugs with devices or not? Saibal.
Well, whether we like it or not, that the ACP trial is designed against warfarin and or dabigatran.
And or.
And in fact, in the randomization, they more probably are powered enough to see the analysis between device versus Coumadin and device versus dabigatran. My biggest problem with the study design is that as we go on, the other two drugs are going to become more popular, and then what do we do? Because now we have three drugs. It's going to be a real problem. So I really feel bad for the new devices coming in, and I hope we don't go into the whole PFO story again, where now it becomes impossible to randomize patients.
That's right. Horst.
I mean, the question, should we do another study against new anticoagulants? I think this is a question of resources. We as a community, as a society, want to invest. If we have enough resources, then it's fine to do these trials. But otherwise, I think all that money which goes to these trials should instead be invested into design better devices. Because when you start asking for these trials, you also should ask for a randomized trial, new drug A against new drug B.
Yep.
And B
and that's
against
what's
C
happening.
and A. Yeah.
And that's what's happening. Unfortunately, when we design these trials, unfortunately, they don't take resource consideration into effect or into consideration in these matters. So they'll say to you, yes, we need this trial, and go for it. So I'm afraid that somebody's going to bring up this point that, you know what, why don't you randomize the Watchman versus these new oral anticoagulants?
But I think we have logic enough to say that you don't have to do it against any drug, because those trials were designed not for superiority. Those trials were designed to be non-inferior to Coumadin. So I think it's
more clever.
Right?
Yeah.
And so if that be the hypothesis, that if we can show that device therapy is equivalent to medical therapy, it doesn't make any sense to do them against every single drug. And that's why
Great. So finally, predictions. So again, for this year, Horst, do you think the FDA will approve the Watchman device?
I'm always positive, so I believe
You're always
they will
positive,
approve.
yes. Saibal?
Well, this time I strongly believe that it's got to be approved, because now there are 2 trials and we're going to show long-term data.
Do you think the FDA has any choice? I mean, they asked the manufacturer to do another randomized trial, which
and we did.
I think it was the first time ever.
Yes, in history.
To
that
request
with
2
in spite of a positive panel.
randomized trials.
Yes.
In
spite of a positive panel and 2 randomized studies and long-term
So
data.
you think they will approve it?
Yes.
For all patients, or?
No, I think there'll be a restriction, and I think most likely they're going to restrict to CHAD score of 2 patients based on PREVAIL trial, though the numbers are going to be high. I don't think they're going to approve it for CHAD score 1.
So will they restrict it to patients who can take Coumadin? Or to those
no,
who
I
might
think
study was
I
not.
Think, no,
Yeah.
I think they will restrict it. At the most, if they restrict it, they will restrict it to people who, similar to the European guidelines, to those people who cannot take long-term anticoagulation.
There's no trial. But
Well,
there's no
that's
single
The
what
trial,
trial.
yeah, no such trial. I mean, they have
So
to
they
approve it
For CHAD
the
score
way that they
Anyway,
designed the trial.
Yes, I agree
So
with you.
otherwise they would require 2 randomized
Well, I think
trials and then
that's
approve
right.
it for
Yes,
something else.
Yes.
Bernie, what's your take?
This time I agree that they will be approved. And then I think we should also turn to a third group of patients, those who may want to have both anticoagulation and LAA closure, maybe anticoagulation on a low level, low dose of a new drug, plus LAA closure, because as we all know, both do not protect 100%. You still have like 20 or 30% of ischemic events that happen in spite of LAA closure or drugs. Maybe if you combine them in a wise manner, you may come down to even less events.
So Ziyad, just one add comment about the long-term data of the Watchman trial. There's actually going to be a presentation in the HRS meeting in a couple of weeks, which is actually going to
When you talk about long term, tell us how many years
it's
is
going
long
to be
term?
4-year data.
4 years is long term in your.
Well, I think in a device study, this is very reasonable. I mean, 4 years.
Yeah, of course.
And if it shows the trend towards the right direction, then obviously it's more likely. So.
Great. Any last points on PFO or appendage before we conclude this session?
Well, my point is I would like to echo the words of Horst Sievert. While we try to do these randomized studies and spending so much of money, we're actually hindering progress in device development.
Yeah.
Because now companies don't have the resources to go for 2nd generation and 3rd generation because they're so focused in completing these trials and spending millions of dollars. And so I think there's got to be a balance of amount of clinical trials and what should be put towards.
I think we should put the patient more in the middle. That's not only true for PFO and LA, it's also for TAVI and other things. You are a runner, as we know. There are other people who climbed the Mount Everest, which has a mortality of 10%, and it's their decision.
That's right. But Horst, I mean, I'm going to, again, play the devil's advocate. If I am the FDA and all public eyes, are on me for approving anything, and in 10 years, if something happens, everybody's going to be demolishing the FDA. So I think, I totally understand their point of view, albeit, sometimes they are too strict, but you look at, the silicone breast implants, you look at other drugs, they approve them and now there are disasters, so they withdraw the drug. It's a problem. They are really, walking very fine line when to approve and when not to approve. So it's tough.
No, I think we should be fair to them, that we should, because something comes out late, 10 years later, we shouldn't blame them for that. It's not their fault. I think.
Well, you say that, but there are people. There were articles,
right.
you know, the JAMA article, where they blame the FDA that you're not doing your homework. You're approving devices easily.
Yes.
They went, you know, over the last 5-10 years, and they looked at the list of devices which were approved, and they said, you know, the evidence was not very strong, and you approved it. So they are, under the microscope. Yeah.
Yes, I understand that, and I realize that. On the other side, not for PFO and LA, but for TAVI, you can actually calculate the number of deaths which occurred because of delayed approval of devices.
That's right.
So the FDA is afraid in both directions.
Yes.
But when you put the patient more in the center, then actually I think the FDA can live with that. If the patient is well informed about the risk and benefit of both procedures, and it's a patient decision, and they make it as a rule of their approval, then I think it would be a solution for everybody.
I hope so.
Device-based PFO closure looks back at more than 20 years of pretty safe history.
That's right.
And device-based LA closure looks back at more than 10 years when Horst Sievert put in the first. With
And
also
it's only
pretty
getting
safe.
better over time.
That's right.
And no
That's right.
devices
The
had to
learning
be
curve
taken out late or anything.
Right.
Great. I want to conclude this session and thank our esteemed panelists for their input, and I hope that you will enjoy the rest of the meeting and enjoy Sol. Thank you so much.
Well, thank you, Ziyad.
Thank you.